Clear, ladies.
Yeah. Good evening, everyone, and welcome to another meeting of Journal Club. And today we have a very renowned, esteemed panel of speakers. And this is the last meeting of Journal Club under the presidentship of Dr. Sirish Thorat, and which is jointly conducted with Bombay Ophthalmic Association. So I would ask Dr. Sirish Thorat to open this meeting. Dr. Thorat, sir.
Yes, thank you, Vishal Bhai, and good evening all. It's pleasure to welcome you all to this meeting. And as Vishal Bhai said, this marks the last official academic event of our tenure. I want to extend my heartfelt gratitude to all panelists and mentors for sparing their valuable time. And I think this is a perfect end to the tenure with the presence of such a regarded faculty. My friend Dr. Vaishal and Team Journal Club, thank you so much for your tireless work which made all this possible. Right from the selecting the articles, organizing logistics, and all the execution, you have done your best, my regards. You all are a great source of inspiration. Thank you for your support and participation over the past year. Thank you, and let's start tonight's discussion. Over to you.
Yes, sir. So I would ask Dr. Parul Deshpande to introduce our esteemed faculty.
Vaishal, first ask Neeraj, sir, because he's
Neeraj,
introducing.
Neeraj, please introduce the faculty.
So, I would like to introduce Dr. Lingam Gopal, sir, who is present amongst us. I think sir needs literally no introduction. Apart from that, we have Dr. Rajesh Joshi, sir. We have Dr. Archana Juneja, madam, and we have Dr. Nitul Bhatt. The entire show will be moderated by Sabyasachi, sir, who is forever our statistics hero. And we are enlightened to have this topic over here, which is very in trend these days. So I would just request Dr. Sabyasachi Sengupta, sir, to moderate the session. And before that, we can start the PG, that is the postgraduate, who is Chintan. We can start the presentation and then we can start asking questions accordingly to our esteemed panelists and moderators.
Yeah, Neeraj, we'll just introduce two of the panelists who are here. I think people don't know them. One of them is Dr. Nitul Bhatt. He's a vitreoretina specialist who is currently practicing in Bahrain. He has done his residency in Mumbai, and then post that he has pursued his the fellowship in USA. And after that, he had a very short span in Mumbai in Bombay Hospital, and he worked as a retina consultant. I think during that time, I got exposed to him. And post that, he has pursued his career in Bahrain. And I think he's there in Bahrain practicing as a vitreoretinal surgeon. The other person is Dr. Archana Juneja. She is a consultant endocrinologist at Kokilaben Dhirubhai Ambani Hospital. And she has represented her well in most of the prestigious national and international conferences, including being a secretary in 2022 in Maha Essex conference.
If you allow
welcome
me, I will
both
introduce Dr. Lingam Gopal, sir.
I thought you introduced.
So I was about to. So Dr. Lingam Gopal, sir, like I said, needs no introduction as well. He is a professor, Medical Research Foundation. He's from Shankar Netralaya. He's done his MBBS in 1979, and he's done his post-graduation from JIPMER, following which he has done a fellowship in vitreoretinal surgery from Chennai, followed which he has achieved FRCS. So he has various accolades. Not only this, but he has 236 publications and around 38 chapters in books. So, sir, it is a great honor for you to be here amongst us. And like Madam has already introduced the other two panelists, so it's a treat for all of us, I feel, today.
Dr. Manish Bapai is a very renowned vitreoretinal surgeon from Nashik. He is also our local state faculty for the club meeting. And I have known Dr. Manish for umpty number of years, and he's a renowned in his field. So without further ado, I would ask the PG to present today's topic.
Dr. Chintan.
Hello.
Can you share your slides?
Yes, ma'am. Is my screen visible, sir?
Yeah, very much.
Okay.
Good evening, everyone. Myself, Dr. Chintan Demande, resident doctor from Yavatmal, GMC. First of all, I would like to show my immense pleasure to be able to perform on the big platform. The topic for today's Journal Club is GLP-1 receptor agonist and the risk of neovascular ARMD. Today's moderators are Dr. Rajesh Joshi sir, Dr. Snehal Bonde ma'am, Dr. Parul Deshpande ma'am is our coordinator. The panelists are Dr. Nitul Bhatt sir, Dr. Lingam Gopal sir, Dr. Archana Juneja ma'am, and Dr. Manish Bapai sir. Statistical experts are Dr. Sen Gupta sir and Dr. Keshivani sir. The GC committee chairman is Dr. Vishal Kenya sir. And a lot of thanks to Dr. Neeraj sir and Dr. Zain sir for helping me for this presentation. So we will start with our presentation. The authors for this study are Dr. Ryot Shot sir and Dr. Andrew Mihalake sir et al. The study was conducted at Institute for Clinical Evaluative Sciences in Ontario, Canada. The study was published in June 5, 2025 in JAMA Ophthalmology, that is the Journal for American Medical Association Ophthalmology. The rationale for this study is to evaluate the risk of developing neovascular AMD associated with use of GLP-1 receptor agonist in patients with diabetes. Introduction. AMD is a leading cause of irreversible blindness in elderly. Almost 196 million people are cases globally according to 2020, and they are to be projected to be around 288 million by 2040. In India, the increasing or rising aging population is causing a rising AMD burden. Neovascular AMD causes 90% of the severe blindness. It involves abnormal vascular growth and macular damage, which is linked to hypoxia, oxidative stress, lipid metabolism, and inflammation. GLP-1 receptor agonists, these are secreted by enteroendocrine L-cell distal intestine, which plays a role in glucose homeostasis. GLP-1 receptor agonists are a group of oral all sublingual hypoglycemics that mimic incretin, which causes or stimulates increase in insulin secretion and causes weight loss. GLP-1 receptor agonists are mainly of two types, one having human GLP-1 backbone and other having exidin-4 backbone. The human GLP-1 backbone receptor agonists are mainly semaglutide and liraglutide, and the ones having exidin-4 backbone are exenatide and lexenatide. The most commonly used in India are semaglutide and liraglutide. The generic names of the brand names for semaglutide is Ozempic and for liraglutide it is Victoza. There were studies, Sustain 6 trial and Pioneer 6 trial, which was conducted to study the adverse effects of GLP-1 receptor agonists. The Sustain 6 trial showed that there was increased risk of retinopathy complications in patients using GLP-1 receptor agonist as compared with the placebo group. And the Pioneer 6 trial showed a 0.8 higher proportion of diabetic retinopathy. The reason proposed for this is the rapid reduction in blood glucose level, which is triggered by a receptor agonist, which causes hypoxic state of retina that promotes further angiogenesis. The materials and methods in this study. This is a retrospective cohort study conducted in Ontario according to ICES database. The study was conducted from Jan 2020 to November 2023 with a 3-year follow-up. The inclusion criteria for this was any adult patient aged more than 66 and having diabetes on GLP-1A receptor agonist. The exclusion criteria included patients who lost follow-up before 12 months or who were diagnosed with neovascular AMD before at the time of diabetes. The study included almost 139,000 patients, of which 46,000 were exposed, that is exposed for more than 6 months on GLP-1 receptor agonist, and 92,000 unexposed, the patients with diabetes who never received GLP-1 receptor agonist. Propensity-based matching was done, which included age, gender, comorbidities between this group. This was a 1:2 matched cohort study, which had unexposed population twice in number as compared to the exposed to increase the sensitivity of the study. This is a table which shows the baseline characteristics between exposed and non-exposed. This included age, gender, the diabetes duration, hypertension, dyslipidemia, any stroke history, CKD, and race. An index date was established as follows. For the exposed group, the index date corresponded to 6 months since the first day of prescribing the receptor agonist. The unexposed group had the same index dates which were applied to the matched. All the participants were followed up from the index date until diagnosis of neovascular AMD or at the end of 3 months of follow-up. Outcomes of the study. The incidence of AMD was assessed in exposed and non-exposed for 3 years. The cases of neovascular AMD were identified depending upon their ICD coding. The coding of age-related macular degeneration is 362 in ICD-9 and H35 in ICD-10, but they are not specific for neovascular AMD. So, to identify cases of neovascular AMD, the Ontario Health Insurance Plan recorded a special billing code, that is specialty code 23, that codes for ophthalmology and medicines such as anti-VEGF along with the ICD code. The results of this study. After matching, we had already discussed the exposed were 46,000 and the non-exposed were 92,000. The mean age of the patient was 66 years. And there were almost 46.6% of women. The patients were almost 98% who were on semaglutide and 22.5% on lixisenatide. The study showed the incidence of neovascular AMD was almost 0.2% exposed and 0.1% in non-exposed. This showed that the absolute risk was very small, but the relative risk, that is the risk factor, was doubled. This is a table which shows the risk of neovascular ARMD in matched patients with diabetes. The graph shows that the table shows that after 30 months of exposure, the crude hazard ratio was almost 3.26%, which highly signifies that GLP-1 receptor agonist usage can cause neovascular ARMD. This is another figure which shows comparison of cumulative incidence per thousand at risk between exposed and non-exposed. This graph shows that after 30 months of exposure, there was almost 2.0% increase in cumulative incidence in the persons using GLP-1 receptor agonist. These are another graphs which suggests that more than 2.5 years of exposure time causes almost 3% increase in hazard ratio after exposure of 30 months. Discussion of this study. GLP-1 receptor agonist usage for at least 6 months causes twice higher risk of neovascular AMD. The risk of AMD is low in both exposed and non-exposed. But when they use GLP-1 receptor agonist, there is almost 3 times high increase. Other drugs such as metformin or SGLT2 transporters, they show protective effect against neovascular AMD, which was showed in recent studies in USA and Taiwan. But specifically, semaglutide shows higher rate of retinal complications such as vitreous hemorrhage, blindness, or non-arteritic AION. Similar findings were observed in patients as what we studied in SUSTAIN-6 trial, which shows a higher risk of diabetic retinopathy with users of semaglutide. The pathophysiology. Insulin resistance plays an important role in pathophysiology of neovascular AMD. GLP-1 receptor agonist can effectively and consistently reduce the insulin resistance in patients with diabetes. But our analysis or our study showed the opposite thing. The pathophysiology can be explained by a flow chart. The retina has a GLP-1 receptor. GLP-1 receptor agonist act on it, which causes increase in the CXCL2, that is an angiogenic chemokine. This CXCL2 causes expression on RPE cells, which boosts the VEGF production and promotes angiogenesis. This might not be the only underlying mechanism, and further studies are required to understand the complex pathophysiology of neovascular AMD. This is the Mary analysis for the study. Methodology. This is a population-based retrospective cohort. The 1:2 matching of cohort was done. Exposure included GLP-1 receptor taking patients more than 6 months, that mainly included 98% of patients taking semaglutide. The outcome was incident neovascular AMD. Analysis. Propensity matching was done. Cox proportional hazard model, that is hazard, it was assessed. Sensitivity analysis was done as per exposure duration. The results showed that 0.2% patients on GLP-1 receptor agonist developed ARMD, and the non-users just developed 0.1%. The adjusted hazard ratio was 2.2% with the confidence interval of 95%. This showed that longer exposure of more than 30 months showed a higher risk. Interpretation: more than twofold increase in risk of neovascular AMD was associated with use of GLP-1 receptor agonists. This is a graph which shows the risk of AMD by duration of GLP-1 receptor exposure. This is a subgroup analysis which reveals higher risk in patients who are females, who have stroke history, and who have aged more than 75 years. The strength of the study is a large population-based study. Propensity score matching was done, which causes significant reduce in bias, and there was clinically relevant outcome with respect to anti-VEGF injections. Limitations: we cannot stratify the study as per the GLP-1 receptor agonist dose or type. Lifestyle factors as smoking and sunlight were not measured. Residual confounding was possible. It is an observational design. There is causation, but there was no association. Comparison with prior literature. Limited prior clinical data was available on GLP-1 receptor agonist and AMD. Animal models suggest mixed ocular effects. This is a first large-scale population-based study. This provides a signal warranting further investigation. Implications in India. The rising prescription of GLP-1 receptor agonist for diabetes and obesity. There is a huge gap of AMD screening in rural and resource-limited settings. We should consider baseline and follow-up fundus examination in high-risk patients. There should be we should encourage collaboration between diabetologists and ophthalmologists. Discussion points. There are five main important points. Should GLP-1 receptor agonist users undergo routine retinal scanning? Do cardiovascular renal benefits outweigh the ocular risk? How strong is the pathophysiology? What research is needed in Indian cohorts? And should AIOS or MOS issue guidelines on their monitoring? The take-home message is GLP-1 receptor usage is associated with twice higher risk of neovascular AMD. The absolute risk is small but very clinically relevant. Clinicians should be aware of the potential ocular complications associated with their use and are encouraged to report any suspected adverse events to post-marketing pharmacovigilance system to facilitate the safety tracking and raise public awareness. These are references for my study. Thank you.
Thank you, Dr. Chintan, for a wonderful presentation. With this, we will move on to our statistical expert, Dr. Sengupta. Dr. Sengupta, will you be presenting your presentation on the statistics?
Chintan, you'll stop sharing?
Yeah.
Yes.
So I'll just go and quickly share like usual. So this is the paper. You're able to see, right? My
Yeah.
screen?
Yeah.
Okay. So, we are discussing something really crucial, right? So GLP-1, or, they're now called GLP-1, right? So like, it's not VEGF, it's VEGF. Similarly, it's not GLP-1, it's GLP-1. So that's the trend. So GLP-1, so this paper mainly talks about semaglutide because 97% of the patients in this is semaglutide. But let's remember that then there are plenty of even newer GLP-1s which are injectables and are taken once a month, sometimes once a week, I think. So, so we're not talking about any of those. We're mainly focusing on semaglutide. From the statistics point of view, so this is a paper which is almost entirely based on how well we understand statistics. So I'll take about 3 or 4 minutes so that we understand what is this propensity scoring and all, because a lot of these are coming up based on propensity matching and all of this. So first and foremost, we had out of the total 72,000 patients who were taking GLP-1, 46,000 were included, and out of the rest, almost 10 lakh patients. Right, that was about 1 million something. So more than nearly 10 lakh patients were not taking. Out of that, 92,000 were selected as controls. So how do you select only 10% out of the 10 lakh, right? So that's done using propensity scores. So we want both the groups to be really equally matched even before we start comparing them. So that's what is done using propensity matching or propensity scoring. Out of the 46,000 who were taking GLP-1, actually 92 had, it's like 0.2%. So that's 92 actually had AMD. And in the non-GLP-1 or the non-exposed group, 0.1% is 92, but they are actually saying 88 had, right? So we are actually comparing 92 to 88. So that real sample size is not 1,39,000. It's actually 181. 181 patients with neovascular AMD. So in the large scheme of things, the number of events is relatively rare. Right, so we are actually comparing 92 versus 92. That's pretty much what we are looking at. So don't get fooled by 1,39,000, 10 lakh and all. Okay, what is propensity scoring? I clearly told you that it is because of we need to match them equally. So I'll tell you what that is later on. Another thing they're talking about is main outcome measure is time to event. Okay, time to event is basically it comes under the analysis of survival analysis. Survival means, it's really timed event came about when we were talking about survival rates in cancer. So we talk about 5-year survival rates or 3-year survival rates. Similarly, we are talking about survival rates. That is, how long will the eye survive before going into AMD? Right, so time to event is really important. And here they actually should have mentioned that, the risk of AMD is higher after consuming semaglutide for these many months. That is not there in the results and anywhere in the manuscript. Right, so that's about 15 months. When I'll show you the graph, you will realize that the uptick is roughly around 15 months. That's 1.5 year of use, roughly, give or take. Right, so after 15 months, there might be higher risk. Okay, when you look at the actual results, the absolute values, it's like 0.2% versus 0.1%. It's out of 100 or out of 1,000, 2 will develop, and out of so out of 1,000 given semaglutide, 2 will develop. But then when you look at the numbers, if 10 lakh are given, then that number is really high. So you'll see that the number goes up to like 2,000, right? So overall, the absolute numbers is all actually small, but then when you extrapolate to the population, then the numbers could get high, right? So then, but yet, so just talking about twofold higher risk, that sounds really crazy. Oh, 2 times higher risk, 3 times higher risk, that's high. But then the absolute numbers is small. So the risk is actually small, not high, but then the risk is there. It's real. When they talk about the introduction, they should actually concentrate more on the the causality. So they actually don't talk about causality. They talk about, okay, what are the numbers that VEGF inhibitors and anti-VEGFs are there, which is all pointless in this kind of manuscript. So this is the only line which talks about causality. So for instance, they say dysregulated lipid metabolism, oxidative stress causes neovascular AMD. But the main problems are age, genetic predisposition, and smoking. Right, so here, as I'll show you, age has also really not been able to match by propensity matching. There is no information on genetic predisposition, and the biggest thing which is missing, especially common in or more important in the Caucasian population, is history of smoking. There is almost a 5 times higher risk of AMD if you smoke versus if you don't smoke from the ARIDS to after 10 years of follow-up. So that's a very high risk. It's here we're talking about 2 times higher risk, right? But smoking is like a 5 time higher risk. So that's even 2.5, 3 times higher than GLP-1s. So without smoking, adjusting for smoking, it's a little bit difficult to, sort of digest all of these. So there is already some evidence that there is substantially higher risk of non-arteritic ARI1. And that risk is also, it is little lower than this, but if you look at the numbers, it is like 7 times higher. But then actually the risk is, but then there is some risk. So, why is GLP-1 or GLP-1 causing increase in hypoxic events in the eye? And so that is what we are really studying here. When you look at this, they say that patients are excluded who are followed up for less than 12 months. So that's a good cutoff. So at least 12 months they should be followed up, and they should be taking at least 6 months of GLP. Right, comorbidities that were matched for propensity scoring. Like I said, we are having 72,000 and 10 lakh. We can't just simply go ahead and compare 72,000 with 10 lakh because it's too much of a mismatch. Right, so to match them, even before we compare, we do propensity matching. Here they are matching with comorbidities like hypertension, dyslipidemia, coronary artery disease, cerebral vascular accident, and chronic kidney disease. So all of these patients across both the groups will have the same number, almost the same. At least they should have the same numbers. So significantly missing, they also say smoking. Right. Importantly, what they have also should have matched was the diabetic retinopathy status, which, after, so these are patients after 6 years of diabetes on a mean, which we don't expect them to have. Another very important thing is drusen, so that is dry AMD. So, nobody actually gets wet AMD within 3 years of taking any drug or 30 months, unless you have some predisposing factor. Like, so most of these who have developed might actually be harboring some intermediate dry AMD like drusens or, like soft drusens and RP atrophy. That's how we define intermediate AMD. That was not propensity matched. So if you actually exclude those with dry AMD, you might actually get 0 events. because within 3 months at 66 to 69, very few will directly go into neovascular AMD. So drusen, the history of drusen and existing drusen has entirely been, sort of, overlooked. Other things are, like I told you, propensity scoring, why it was done, and other things. So how do we do propensity scoring is, really the question is how well are these groups matched, right? So what is the incidence of AMD? So 63% of GLP-1 were taken, but the rest 37% were not taken, right? So what is the incidence of AMD in those who are not taken? There are many more robust measures of propensity matching, as in how, everything rotates around how well should we trust this propensity matching. If it is matched well, then the results are great. If they are not matched well, like smoking and non-smoking, we don't know, then the results are a little bit shy. And then there are many other methods of propensity matching, and many things that can be reported on the robustness of this propensity matching, especially something called inverted probability weightings. I won't go into the details, but there is not enough on how propensity matching was done other than caliper distance was used or caliper method was used. There are many other methods. The optimal method is slightly better for these kind of data sets, but it is best to do propensity matching by two different methods and then do the whole analysis and see whether you're getting the same results, which actually was not done. Purists. So, from a purist point of view, that is how it would be. From the results, we come to, from the methods, we come to the results. So, as you see, semaglutide is 97%. This is an oral medication, and so almost entirely, this is about semaglutides, and this is, I already told you, so 0.2% versus 0.1%. So it's relatively small numbers. When you look at this propensity matching scoring, the mean age is 66.3. The minimum inclusion criteria was 66 and above. So then 66.3 means everybody is roughly 66-year-old. This happens, this very small range happens because of propensity matching. When you look at the unexposed group, it is 66.2 and the exposed group is 66.4, right? And actually, this is not p-value as we would expect. This is SMD. This is not a p-value. So SMD, as they give here, is standard mean difference. Right, that what this really shows is how well they are propensity, how well they're matched. So anything less than like these very small numbers means excellent matching. Anything which is more than 0.05 like this means the matching is not that good. Though they say 0.1 is the cutoff, but this matching is not that great. And here, actually, if you would have a p-value, this is significantly older. Exposed to GLP-1 are about a 1/4 year older. So perhaps makes a difference here. So even with propensity matching, age could not be matched exactly. I would like to see a value of 0.001, but they were not able to because the GLP-1s were much older. It looks like, at least from here, right? And even if these are very close, a quarter of a year should not matter here and there. But importantly, age is the main risk factor for neovascular AMD, right? So then if age is not matched, again, a little bit, so it casts a shadow. Then when you look at, we talk about dose response. So here with 6 to 18 months of exposure, about 0.03% got neovascular AMD. With 18 to 30 months exposure, 0.07% got. That's higher. And more than 30 months of GLP or GLP-1 use, 0.12%. As you can clearly see, the longer they take GLP-1, the more the chance of neovascular AMD. And also they show the same thing in this graph, right? So this is 0.5 to 1.5 year. Both of these are pretty overlapping. Here, if you see, that thing goes up and it again breaks at 15 months. So from 1.5 to 2.5 years of GLP-1, there is, these are separated. And again, when you see this to more than 2.5 years, there is again a separation, right? But then is this significant statistically? Remember, these are all, 2 out of 1,000, and this is 1 out of 1,000. Is this statistically significant? Is something that they don't report. So there's no formal test to report on trends, right? So P for trends or these slopes. And, so alternative explanations could also be there, especially, residual or unmeasured confounding, like smoking, can also explain this gap, right? Selection bias, that is propensity scoring, has not been done as well as we want it to be. And there are many other explanations, of course. So I have thought about some, but then, overall, these are some of the critiques. And, lastly, when you look at the multivariable modeling, this is the multivariable modeling. What causes, in addition to GLP-1, is there anything else which increases the risk of neovascular AMD? Of course, age. Age. So every 1 year increment in age increases risk by one, that is 12%. That's quite a high risk, right? So if somebody is 2 years older, that's 24%. 3 years older, that's 36%. Of course, women, it was not significant, but still 26% higher risk in women, and cardiovascular risk is there. So overall, remember that smoking is not there in this, right? So smoking is very, very crucial. It's a strong risk factor, especially white races. So, so you can actually do some analysis to see how much of the whole effect is being explained by these covariates and how much it is not. Right. So, uh, we get a lot of metrics. I have listed them some here, like Rosenbaum bounds, E-values. But then, given all this, how much of the effect of GLP-1 on neovascular AMD is being explained by this whole model and how much is not? So if the strength of the model is 60%, that means 40% is by other confounders. If it is 70% strength, then it's, then smoking is maybe responsible 30% and genetic factors some. If the strength of this model is 90%, then maybe smoking is not at all informed, it's not influencing. So we don't know what it is. So overall, sort of take home messages, if there is a 70-year-old lady with a past history of stroke, right, and with some drusen or a PED, that is, there is a slightly higher risk for neovascular AMD, I think we should perhaps refrain them from starting GLP-1 agonists. Remember, we are not the ones starting these GLP-1 agonists. Who's starting is the diabetologists. So, or people, helping with weight management and other things. So, it's imperative that they do this kind of screening before starting GLP-1, not only to know the, degree of diabetic retinopathy, but also to know the risk of neovascular AMD. So overall, in conclusion, I think, some points that I've noted is risk is small but significant. And there are other things which I don't want to discuss, but 1 in 1,000, like I told you before, can develop. So if 10 lakh are given, then we'll see 1,000 new patients. Smoking is not accounted for, it's a major bias. GLP-1 for obesity, so this is only for diabetes in elderly. What it does for obesity in slightly younger patients, we don't know. There is definitely more, more to study on this. So these are some of my statistical, takes on this paper.
Wonderful. I think sir has described everything statistically, and it is beautifully explained by sir. If we can now start asking questions to our panelists over here, if Dr. Chintan's mentor, if you have anything to put in her feedback and her some tips on this entire article, and then we can go ahead with our experts. Dr. Archana Juneja, madam.
Yes, sorry, I missed you. You asked me?
Madam, if we can have some knowledge on the article from you.
Yeah, so at the outset, thank you for inviting me. And this is a very clinically pertinent topic. I'm glad you are discussing this. A few points were eye-openers for me too. So a few things that this study looked at only semaglutide and a small portion of lixisenatide. Now, actually, we've been having GLP-1s for more than a decade. We had exenatide and then we had liraglutide, which was very commonly used for the last 10 years. But at that time, we actually didn't talk about ARMDs increasing, or we didn't talk about NAIONs also. So my question was, did you see a lot of NAION in the before the last 2 years, before semaglutide came into vogue?
Dr. Lingam Gopal, could you please answer, sir?
Yeah, I think I have a few comments. First is, this is really not a population-based study. It's a health record-based study. They have not examined a single patient for the sake of this study. They just took out the ICD code and then did analysis. And ICD codes are notorious to be even wrongly entered and wrongly labeled by the clerical staff. So there is a possibility of error remains, although they did clarify that it's neovascular AMD specific ICD code is what they have written. But I still believe that health record-based thing has to be taken with a pinch of salt rather than when you examine the patient. I think the points which Dr. Sen Gupta made are very, very valid in terms of drusen. That's the most important risk factor. It's not even been commented upon at all. And I think without that, trying to make a major conclusion that the drug intake is actually responsible for that is definitely not possible. Of course, they themselves agreed there is an association, not a cause and effect relationship. We accept that. So at the most, this could be a signal for further investigation, no doubt. But I think the major lacuna is that the ocular risk factors for AMD have not been elucidated at all. And that I think is the most important factor. Then they said, does it impact our management in the sense these diabetologists going to stop prescribing the semaglutide just because one paper says it increases the risk factor of AMD? Not really, because in terms of substantial risk, is there or not 0.1 to 0.2 is not a huge difference for us to think of recommending them to stop it. So I think for the time being, we have to take that as just a signal. And I'm sure there'll be umpty number of more studies which will be more focused on starting with the ocular features also noted in the first baseline data to see how they developed into AMD or not. And although they adjusted the other factors have been adjusted, they have not adjusted for the ocular factors, and that needs to be adjusted. So that is where we need to stop, not look too much into this paper as a sort of a important landmark paper. It's just an indicator that we should look at it a little more in detail in the future. Thank you.
Yes, so that's a very interesting point, sir, if I may add, because we've been prescribing the older versions, and then in the last few years, in the last couple of years, semaglutide oral has been used rampantly for diabetes management as well as for weight reduction, even in pre-diabetics. And in fact, today we have a few studies going on for use of semaglutide in young girls, obese girls with polycystic ovaries. So, the spectrum is expanding. Now, in that, so this was the oral group, and now we have the injectable semaglutide and we have injectable tirzepatide, which is even more potent GLP-1 with impressive weight loss. Almost the propensity equating to bariatric surgery. So we have a lot of obesity patients who are obese, overweight, with or without pre-diabetes or diabetes, and they come to us for the obesity clinics, trying everything and wanting to lose weight. So when of course they Google everything and come, but even if they didn't, it's probably our duty, and we do warn them of all these consequences, because now there are a lot of lawsuits happening against Ozempic. I mean the injectable semaglutide. And if I was reading the trials with tirzepatide, also show increased risk of all these retinal complications, of especially worsening of diabetic retinopathy as well as NA non-ischemic, non-arthritic ischemic optic neuropathy. So agree the numbers are very small, but I guess if it's NAION, it's for that patient, it's going to be a little debilitating. So something which we also counsel about acute pancreatitis. So numbers are very small but for that patient who develops acute pancreatitis, it's going to be significant morbidity, hospitalization, and in fact, I think there was a report of mortality with, fulminant pancreatitis with this injectable GLP-1 receptor agonist. So numbers are small, but when it comes to a person-to-person interaction, so I guess what we do is screen every patient, take every patient on an individual basis, and just for safety sakes, because we are still in very early years of these potent GLP-1 receptor agonists. As a routine, we endocrinologists across the country, we are getting a baseline of THAL evaluation done. So the worry is the next year we have semaglutide oral in our country, but it's very expensive right now. But next year it's going off patent, and then semaglutide is going to be flooding the markets. So at that point, even the GP is going to be prescribing semaglutide. So now that situation is something which we'll need to be geared up for. So right now, we as endocrinologists across the country are getting a baseline eye checkup done to look at, these risk factors, if there's any diabetic retinopathy, non-mild or moderate or non-proliferative. So proliferative patients, we are not using them. But drusen is one thing which we came across, which I get to your point, whether patients who have drusen, whether should we get them onto or should we not? And even if all these patients were normal at the baseline screening, as the study says that as years of exposure go by, the risk increases. So even if we do a baseline, do we need to repeat them every 6 months or 1 year, or we just warn them about the red flag? And then we tell them, whenever you notice any symptom, please report back. Those are some unanswered questions. So one is, what do we do on follow-ups? And second is, is there any association with, the potency of the GLP-1, the dose and duration? We already have some pointers, but I think more studies, I think RCTs will probably tell us the answers. These are some questions. So what we do.
There is one important point there, that every diabetic, irrespective of the duration, especially the adult onset diabetics, are anyway asked to get a retinal examination done on a yearly basis, even if there is no retinopathy. So that screening is anyway being done. When retina is being examined, the doctor obviously is going to examine the macula as well. So in that way, screening is mandatory, not just because the semaglutide is associated with AMD risk, but because the patient is a diabetic and is exposed to diabetic retinopathy risk. So that way, I think screening is mandatory, no doubt about it. Do you want to add to that an Amsler chart monitoring and ask the patient to monitor his central vision? Yes, no, there's absolutely there's no reason why you should not do it. But specifically, if somebody has high risk factors like soft drusen more than X number in the macular area, etc., with high risk of AMD, then yes, even otherwise, even without he or she being on this particular medicine, we would give them a home Amsler monitoring. Even routine patients with 6/6 vision, no complaints, having soft drusen in the macula is a recommendation for home Amsler monitoring. And a routine examination every year at least, minimum every yearly. So that anyway is already in place. Whether you want to increase the frequency, well, maybe yes and no. Instead of calling them once a year, you want to call them a little earlier, maybe you may. But as it is, I think the evidence is still not strong enough for us to change the practice pattern. Our practice pattern can still be the same, except if you really want to play safe from the medical legal point of view, you can tell the patient there's one study which says it slightly increases the risk, but it's not proven. It's a health record based study, not a patient based study. We will look for more evidence in the future to tell you exactly whether you are really at higher risk or not. That's where I would leave it, not really dig too much into it from this study alone.
There are a lot of studies, sir. That is the worry, and it's probably might come up as a pancreatitis is a black box warning, and they're now adding NAION, not ARMDs, but NAIONs. That's what they are adding. And other concern.
There was a lot of discussion on NAION in one of the neuroophthalmology. I'm not sure what was the consensus, but not everybody agreed that the cause and effect relationship was established because diabetes itself is a risk factor for NAION.
True.
Not necessarily.
It's just an association, not a cause and effect relationship, causality. True.
Dr. Nitul Bhatt, your experience with the same?
Yeah. Lot of things actually has been put forward by Dr. Gopal, my previous speakers. But one thing is what I find I agree that they have not taken into consideration this. They've not taken into consideration whether the patient had a pre-existing any changes of the drusen or any other things. So it's very difficult to just say that how this direct correlation is very difficult. And they themselves mention it's basically association and not a cause and effect kind of a thing. So that's number one. Secondly is first, what question comes to my mind is why did they take up this study? Why they said there's association between the macular degeneration, the wet form, as well as the semaglutide? Why not say semaglutide and cataract? Probably the back of the mind must be that there are certain reports previously published which say that if you suddenly lower the sugar, you can increase diabetic retinopathy because of the hypoxia. And as the madam mentioned, that there is an evidence of increase in AION, non-arthritic in patient taking this semaglutide. So probably hypoxic theory they took forward and said, okay, maybe there is association between the wet form of ARMD as well as this. So the first question is, normally when we do a study, we have something at the back of the mind. Why would we do this study? I mean, it's not out of nowhere, just you do the study and find out the correlation between this. All other drawbacks have very nicely put that, it's basically the smoking is not included. It's a retrograde study. all this retrospective study, all this have got limitations. And in my practice, I mean, again, it's a very, very small number. And I don't think it matters much, because we do the same kind of, most of the people, when endocrinologists here in Bahrain, when they start on the medication, the patient do come to us and have a proper checkup. And that's it. And normally we got a 6 monthly, they send the patient back for follow-up. But I have not seen any, again, I have not done any studies. The numbers are very, very little to say whether this semaglutide changes of macular degeneration or AION or increase in diabetes. I have not come across that particular thing. So yes, I will keep in back of my mind. Yes, there is something I have to be careful, but it doesn't change any the way we practice at present time.
Thank you.
Parul, can
Dr.
I
Yeah.
just before
Yeah.
we go to Manish, I just wanted to share one quick thing. It's again a statistical sort of a thing, is very helpful to, for most things. So there is something called numbers needed to treat or numbers needed to harm. So this is basically, you can do it with you need a 2 by 2 table where you say exposed versus non-exposed and disease versus no disease, right? So like we have here, right? I mean, how many had and how many didn't have, and how many total were given versus not given. So, this is not number needed to treat. This is numbers needed to harm, because we are talking about an adverse effect. Numbers needed to treat, say, for example, is like, prevention of endophthalmitis with moxifloxacin intracameral. That would be NNT. Now you're talking about NNH. The formula remains the same. So it is 1/1 divided by the risk in exposed versus risk in non-exposed. It's very simple to do. So this is basically, this is 92 divided by 46,000 whatever. That's 0.002. And risk is basically how many got versus how many were in the total. So this is, and the other is 88 divided by whatever that number was, 92,000 something. So this is about 945. And there are way to adjust using, because this is a rare event now. So the overall number is about 870. So with every 870 prescriptions, you expect one to get AMD, especially if they are more than 66 years of age, with history of stroke and all of those other things that are given. So this number needed to harm is helpful to see. So this number needed to harm for non-arthritic AI, when I calculate, it's like more than 10,000. One in every 10,000 is likely to get an AI1. But here the number is like 1,000. Right. So I had actually put it up in the conclusion section. So, you can do this with any study that you're looking at. It's relatively simple. So when you look at this, risk is small, but significant. Why? Because that number needed to treat or harm, that is 1 per 1,000 prescriptions. Imagine when semaglutide, I'll just stop here. Imagine when semaglutide is going into the market and it's off label, then, 10 lakh, like out of a crore diabetics, 50 lakhs are going to take semaglutide. Right. So then if you're looking at relatively large numbers, right? 1 in 1,000. So out of 50 lakh, we are looking at very large numbers. So then, I mean, it could happen. I'm not saying it will. So if this really happens, we are all going to see more neovascular AMD, right? And also a little bit earlier, like in their mid 60s, late 60s. So, so I just thought I'll bring out the concept of numbers needed to treat or harm.
One more thing which I probably felt was that when we are using this agent for diabetes, is it the same when you are using it for obesity? So it has been used as a weight reduction. So will it cause the same kind of effect? Because diabetes itself is a risk factor for us in for the retinopathies. So will that also be same risk in patients who are actually looking at weight reduction without diabetes?
So when you look at the SUSTAIN 6 results and some of the other large clinical trials, so patients with diabetes actually have shown worsening of diabetic retinopathy. In those large pivotal trials, diabetic retinopathy has worsened in both of those studies. So, but then when you look at this only for obesity, the evidence is more sketchy. But diabetic retinopathy seems to be worsening. AION seems to be more. AMD again, it seems to be, so of all the places, the eye seems to be the center of all the problems with GLP-1 so far. Maybe they are better studied, I don't know, but somehow we need to watch out a little bit.
Yeah. Just one point I wanted to make. Patients who have frank diabetic retinopathy, how many of you have seen AMD developing in the eye? Patients with diabetic maculopathy in PDR, we hardly see them developing age-related macular degeneration. Something to do with the ischemia of the retina, probably causing reduced risk of AMD. I'm not sure, but the association is actually quite low. So if patient already has a diabetic retinopathy, that itself may be actually protecting him from AMD. I'm not sure. I'm just start thinking aloud. So all these factors have to be analyzed. So if at all you want to answer the question, there has to be a prospective study. We cannot answer it from health records. That is probably the very flimsiest evidence we are looking at, based on which we should not make large-scale decisions. We should only just say, okay, this is a signal. Let us investigate it further. That's all. That's where we stop. I was just reading the literature on the similar risk for NAAOM. Even that is similar to this, more of a population-based, record-based study, not really a prospective study. But based upon that, the European agency has recommended that in the drug prescription, the drug information booklet, they must add this point that there is probably a slightly increased risk of NAAON. That they have included now, the European agency. So, well, based upon this, I'm not sure we would recommend that, but I think probably this may be starting point for more prospective studies.
So all these studies are based on propensity matching, So it's very important for us to now understand what is this propensity matching. So the US has very recently, coming out with saying that acetaminophen or Tylenol in their country causes problems and autism risk higher in pregnant or pregnancy intake of Tylenol. So
We have some comments from Dr.
those are
Manish.
also mentioned based on propensity studies. So propensity scoring.
Yeah. So can we have comments from Dr. Manish?
Manish, yeah.
Yeah. So I think when Dr. LG sir and Sabyasachi are there, it's very difficult to add to anything. But I think we have to keep in mind that this is a study which is, as sir said, it is a health record-based study. There are a lot of things which which are probably though they speak about the GLP-1 agonists, they haven't really spoken about what dose they have used, what route they have used. They have not taken into consideration sunlight exposure as well. If there is any mislabeling which is done, that might be another confounding factor. What Dr. Parul was asking about non-diabetics, what does it mean for non-diabetics being treated for obesity? This paper definitely doesn't answer that question. It doesn't really, you can't generalize the results of this study. In fact, this study is, since it is health record based to a particular geography and to a particular age group, I think we need to have a lot more studies from different geographies which can answer this question. And as Sir has said, I think we can take probably this as a starting point where more prospective studies are better designed, or well-designed studies can answer a lot more questions. This paper, they have spoken about AMD, but they don't speak about coexisting diabetic retinopathy as well. Whether that worsened in these patients, they don't speak about that as well. So, as Dr. LG sir has already said, we can take this as a starting point, where this paper says that there is a twofold higher risk of elderly patients who are on semaglutide more than 6 months, who can develop neovascular AMD. So, from ophthalmologist point of view, we should be asking the patients who are coming to us, diabetics who are coming to us for ophthalmic checkup, whether they are on semaglutide, and look at them more carefully. And for the physicians and endocrinologists, I think it is quite important that they take back home the message that regular retinal evaluation at the beginning of their treatment, as well as intermittently as the time passes, because since this appears to be dose dependent and temporally adjusted, there is a higher risk. It increases as the time passes. So from physicians' point of view also, it is important that they get regular fundus examinations done. It's not only when the patient, as madam said, should we ask the patient to go for eye checkup when the patient is symptomatic? Probably that's too late, because the patient may get symptomatic when they develop vitreous hemorrhage because of developing proliferative diabetic retinopathy. So regular examination of fundus is quite important for your patients, and that's irrespective of whether the patient is on GLP-1 or not.
See, what Dr. LG sir has said, one point is that whether diabetic retinopathy and AMD how many cases do coexist together? So does diabetic retinopathy have a protective effect? That is another thing which we should think about.
One more thing that I wanted to ask was that can obesity be also a confounding factor in addition to what they have described, like, age, the cardiovascular diseases, and other things, for patients to develop ARMD in patients who are taking these medications? So, Dr. Gopal, if you can.
I don't think obesity itself has been identified as a risk factor for AMD.
So, one
So
of the
whether usage of the semaglutide in obesity increases the risk, I don't know, frankly, whether literature has come up with that kind of information. But as of today, I don't know whether obesity really is
I
important.
was going through one of the comments to this article, and one of the comment was mentioning about the obesity as a reason for
benign
ARMD.
intracranial
Yeah,
ARMD,
for ARMD
FAI.
also, yeah. So that also increases the risk. So if you are not treating it with this medication, you are increasing further risk. So that is what was their interpretation. So I don't know whether that causes.
So what I read about was obesity increases the risk of benign intracranial hypertension, and whether that has an effect on NAIN, that we don't know. But as I said, we using these molecules not only for diabetics but also for non-diabetic obese people. So there also we are getting a baseline check, not for retina. I mean, not just as a baseline check for maybe drusen. We don't know what we're looking, but just get a baseline check to see everything is okay. Maybe drusen is something which will be a red flag for us. So obesity, yeah, I think these are all last 2 years. All these risk factors are coming up, and all these side effects are coming up, which are serious and potentially can land up in legal trouble. So it's better to be careful. So till we have more evidence. And so I'll tell you, 10 years back, we had these molecules, the incretins, which were the DPP4 inhibitors. And there was a huge talk about risk of pancreatitis with that molecule. But today, all that has been laid to rest, and it's one of the most commonly prescribed medication. So
it's something similar to oral contraceptive pills.
yeah,
So there
and
was
HRT.
yeah,
Yeah,
there was this thing that there is an increased risk of
yes,
DVT, but
yes,
now I think it's one of the most common.
true.
Yeah.
One other point which I thought was, we as endocrinologists don't really like pioglitazone, but pioglitazone has had its own issues with the eye, in terms of macular edema as such. So, when patients with diabetic retinopathy, we don't use, but that's only a small section of of the endocrinologists who don't use it, but a lot of GPs use it. And how do we do when people are on pioglitazone and GLP-1 both combined together? That would be one interesting angle to see. I mean, with diabetic retinopathy, we generally wouldn't use pioglitazone.
Yeah,
So,
I think macular edema worsening or even occurring because of the thioglycins is very, very common. It's not uncommon at
yeah,
all.
yes.
But I heard a patient who himself realized that the
Hmm.
minute he started the drug, his macular edema occurred,
That.
his vision dropped, and immediately stopped. The medicine is okay. I think that is one point up which is well established. But this part is still not established. I'm not saying that we should foo-foo this paper. I'm not saying that. What I'm saying is that as of today, still the evidence is not strong enough for you to change your prescription pattern based upon this paper alone. Maybe in the future, if you have a little more stronger data to support the fact that somebody who is already at a risk of AMD, which will enhance the risk, then maybe we will probably say if somebody has soft drusen in both eyes or one eye already lost due to disciform scar, then probably should not use this. May come up in the future, but not as of today.
So there
Yes,
is
they do.
there is some
Sorry.
evidence that metformin is protective against neovascular
True.
AMD, and then many
SGLT2
other drugs have
inhibitors.
shown some
Yeah.
protective effect actually. So I remember one editorial by Shobha Shiv Prasad in I. Now she is the editor of I and is going to finish her tenure soon. But so she has actually written an editorial, I don't remember when, 2023 or something, where she says that it's worthwhile to test these drugs to see whether they prevent uh, neovascular AMD. These. So she's actually written it's worthwhile to test whether the GLP ones prevent neovascular AMD. And the premise of the current study was also that we feel that it would actually prevent, but then we have found the opposite.
Yeah,
And
they
we
were
clearly
working
talk
on that
about it in the
insulin
discussion also.
resistance hypothesis, and instead
They
of
talk about it
preventing,
also.
helping, it didn't really help, and maybe there were some adverse reports which came up.
So then the authors actually were surprised at what they found, because they actually felt that the risk would be lower, but then the risk is higher. Sometimes, so, a lot of the answers to this is in the way propensity matching is done. It's very important to therefore understand whether these are well-matched groups or not. That history of smoking and bruise and all that is not there. So the matching is not exactly as good as it could have been. And the, results later on don't explain how well this model explains the, the covariates, how much they explain and how much is still left behind.
Despite this, we can't ignore this data.
No, that's what. So then, we need to ask what drug are you on? And then maybe, we should sort of think about creating a VRSI database where anybody who sees neovascular AMD in a patient who is on semaglutide, perhaps, it's like a registry or something like that, where, we make we have these for anti-VEGFs and endophthalmitis and all that. But even, because in India, there's no way to know. Absolutely no way. So if anybody sees a side effect in a patient who's on GLP-1 agonist, reports it to VRSI. So in a year time, we sort of have a little bit of information on whether this is really happening or not.
Yeah, I think we are short of time. So, Vaishal, I think we can have one final
very quick point about the protective effect of diabetes. There's one study from Greece which has shown very clearly that the 5-year prevalence of AMD in DR patients was 9%, while in those diabetes without retinopathy, it's 11.5%. And they say that diabetes retinopathy could actually be protective against AMD. That's one of the conclusions. Yeah, thank you.
So any final comments from the other panelists?
You are on mute, sir.
I just want to ask one thing, Dr. Joshi here.
Yes.
Are the changes which develop after this drug, they are reversible or not? If you attribute the changes on the macula because of this drug.
Dr. Lingam Gopal, I think probably.
I didn't get the question. Can you repeat it?
So whether there are reversible changes of the ARMD, if you stop the medication, will it reverse?
It depends upon what stage you're looking at. And I'm not sure, as I said, nobody has proved in the first place this drug is causing AMD. It's just that it increases the risk of AMD. That's all it says.
Association is there, yeah.
So even if it is, the association is strong, how it is actually causing the AMD, nobody knows. But basically, if somebody has no propensity for developing AMD, it's unlikely this drug itself is going to create AMD in an eye where there's no drusen, etc. Neovascular AMD is not going to take place. It's just that you need to have something already which has made the RPE sick and the plexus membrane is damaged because it's thickened, etc., etc. Those are the basic anatomical trigger factors which have to be there. Only following that, these are all added factors, whether it is smoking or hypertension, etc. So these are going to make it easier for it to convert into a wet AMD because of some reasons which we don't know exactly about. But I think basically you need to have anatomical changes taking place due to the age.
I would look at it in terms of predisposing and precipitating factors. Predispositions are the ones where you are higher at risk, and then precipitating is something which is pushing you over the line. If somebody else has an anti-VEGF requiring neovascular AMD, that Lakshman Rekha has been crossed. So even if we stop the drug, I don't think it's going to come back theoretically. But in the first place, it's very difficult for us to say, the causality that this has happened because of this is really very difficult to say. Many questions like that where, demyelination because of the COVID vaccine, acetaminophen causing, or any vaccine causing for that matter, autism, or, so it's almost impossible to attain causality with high assurity. But then, the signs are there. We need to be on the watch out a little bit. I think more importantly, diabetologists and endocrinologists need to be also on the watch out whether they are seeing more of this, because they would see more than any of us individually.
Right. So this discussion has been very enlightening and it has opened up many points about the use of semaglutide and the GLP-1 and there are whether it's an association or a precipitating factor. So I would have a final comment from a neuro-ophthalmologist, President BOA, Dr. Himalini. What is your take? Have you seen how many non-arthritic optic neuropathies in your practice?
So thank you, Vaishal, and good evening, LG sir and everyone else. To be very honest, I haven't come across ischemic optic neuropathy in a patient with Ozempic or any of the GLP drugs. But, saying that, it is not really the drug itself from the articles that I've read, but it is the rapidity with which the sugar is brought down. And like Sir mentioned, that any which way is a diabetic patient is prone to an ischemic optic neuropathy. So you really don't know whether the drug is causing it or whether it is the natural tendency, or maybe being obese, he has OSA also, because obstructive sleep apnea itself is a risk factor for ischemic optic neuropathies.
So again, this is not an associating factor, but it can be a precipitating factor. That's what you are contributing.
Yes.
Fine. So we had a very meaningful discussion today. I thank all the panelists. I thank Dr. Nitul Bhatt for sparing his time and joining us from an international fora. I thank Dr. Lingam Gopal sir for sparing time for us and joining our journal club meeting. Dr. Manish Bapai and our diabetologist, Dr. Archana Juneja madam. And this was the first time we had a non-ophthalmologist on the forum, because the article was involving diabetes. So we wanted a facet from a diabetologist also. And would thank Dr. Sabyasachi. Your statistician analysis was, as usual, great, and lot of insights on it. And thank Dr. Parul. She had to go for a Dandiya Ras today, but she postponed that and joined for the meeting. Thank you so much, Dr. Parul. Dr. Zain, thank you. And Dr. Neeraj, thank you. And not the least, Dr. Rajesh Joshi for helping me and promoting your PG to present in this forum. And you have always been encouraging the PGs. I thank you for that. And this is the last journal club meeting under MOS and BOA. So I thank both the presidents, Dr. Shirish Thorat sir and Dr. Himalini Saman, for promoting this activity. Thank you so much, and Entod for hosting us. So Neeraj, any concluding remarks from you?
No, sir, I think you mentioned everything. So I think now it's we're already short of time now. So I'd just like to thank everybody for joining us. And now I think we'll meet in MOS in a couple of days, and we will probably discuss the next Journal Club season 3, season 4.
Season 5.
Season 5 very soon. Yes.
Okay. Thank you so much, sir.
Bye, everyone.